A very good morning, ladies and gentlemen. I would love to explain a little bit my background. I'm an oral surgeon based in Luxemburg, and my goal was always to focus or to intertwine the general health and the oral cavity. So pluralistic means that we should be very open for various aspects in medical treatments. And we know that we use a lot of different materials in oral surgery and in dental medicine that might have an effect on long term to the patient. Some are very beneficial, others won't. So for that reason, I was always focusing a little bit on the impact of materials to the general health and the impact of disbalance in the oral cavity of our patients. We do have various data that show a lot of health issues that have their origin in the oral cavity. We're talking about diabetes, we're talking about health issues like heart problems, stroke, preterm delivery in pregnant women. We're talking about blood pressure. We're talking about chronic diseases. We have a lot of scientific data on that. So our goal is to focus a little bit more on the prevention than on the treatment of our patients. In addition to that, we use materials like composite resin materials on a daily basis. Since decades, we use titanium implants on a daily basis, but nevertheless, we see more and more people showing reactions in terms of allergic reactions or at least hypersensitivity reactions towards those materials. And on the WHO conference in 2021, it was decided that in the future, in the next 8 to 10 years, in Europe, European countries should address more the oral health, and every European country should develop a program that should enhance the oral health on a long term of our patients. It is nothing new that we know that if we have caries or if we have a periodontal problem, that this can arise on long term a very heavy, severe health issue to the patient. But we need to focus a little bit more on that in a preventive way. We should not only treat our patients, we should prevent those issues. So pluralistic health means to me as well that we consider new treatment concepts that are dealing with these things.
Yeah, when you start talking about the new concepts of dealing with the healthcare systems over there. So back in India, when we started Medawatar, I'm myself Nanda, I'm Chief Marketing Officer of Medawatar. So when we started working on this, we wanted to understand what exactly is the problem that we are trying to handle there. Because converting the PHR, EHR and EMR reports into digital records and sharing that to the patients is a very difficult task. In a country like India, we are talking about a population of 140 billion. So when we start discussing about like these informations, we wanted to do our testing through some kind of NGOs. So these NGOs are helping elderly people and also the people who are coming from the rural areas. So we are expecting a population of total 20 to 30% in overall India. And we started from the southern part of India, so how exactly it's been manipulated with all the informations. Then we got to know, as Donald was discussing about the snow which is connected to multiple standards, we have a lot of fragmented data. if you go and check with any of the hospitals, say if a hospital A and B, C is there, each and every hospital having multiple entries of the same patients in their records. So we were not able to solve that issue itself, because if, say for example, a patient is gone at the age of 30, he's having one kind of records, and the same patient, if he is not able to go to the same hospital as because it is growing very high in cost, he is going through the NGO, and NGO is creating a new record for him. So we wanted to solve all these problems. So we thought like we would bring an aspect of creating a blockchain identity using their Aadhaar, which is a kind of a social security number in US. So that will be able to connect and create an alphanumeric identity for them. So it's a patented technology, we created that. So once after you create a blockchain entity and you try to connect the interoperability between the hospitals were not ready to accept because they were running on multiple standards, especially like hospital in Apollo. We had a rough calculation of 20 specialty hospitals under the testing. So they have completely taken care of another hospital because they're acting like an enterprises. If the other hospital want to connect with the different hospitals, say the one hospital is running with ICD-10 and another hospital healthcare system is completely running with HL7, the integration is like very complex for them. They're not able to do it only. So they are running the old software which they already have it there. So when we entered into that kind of a market, we gave the software for free for the healthcare systems so that we were able to connect with the labs and diagnosis centers, blood banks, and also with the other hospitals and small clinics, where the patient will be holding a card. That card will be having a private key, and the device which will be there in the healthcare, in the hospital, will have a public key. So that even when you go and tap it, you already have the Aadhaar information there, and the data will be pulled out here. So once you tap it, you'll be able to connect with any kind of hospitals wherever you go within India. And now we are already connected with 17 hospitals, which is there in Bangalore and other regions of southern parts. So slowly we are taking forward it. But still, when you talk about, again, we are coming to the standards, there are multiple N number of standards are there. It's not that easy to connect with all the healthcare system because of that standards only. So when we try to solve that issue itself, like we are giving the software for free with multiple standards, which we already given, like 6 or 7 standards that we already have it, including FICRA and HL7 and all. So once you give all these informations to the hospital healthcare system, they'll be converted to our environment. Once the environment is completely migrated, there is a separate migration process also happening, but that's a tedious task. So when you talk about the pluralistic aspect, we have a lot of disadvantages. Just because of the fragmented data itself, you don't believe we had a data of 40 TB, which is like very difficult to put it in the cloud. Because I was working as a cloud architect. I know if for transferring a 10 TB of data into AWS or a Microsoft, it will take at least 2 weeks of time. When you talk about a data of trillions of informations are there with multiple healthcare systems, it will be taking around like 2 years of total migration work, which is very difficult because in that 2 years, again, a same person will be having a different sets of records in a different standards. So this is the biggest problem that we are trying to solve it. And hopefully, yes, there is a new technology which Mr. Andre is following that. We are trying to work with him to see what exactly is going to happen. Andre?
Thank you. Andre Rafnsson, I'm CEO of Oncotech Nordic. We are a UK, Swedish-based company and have developed an app where you basically, by your own mobile phones, can scan your iris, and we're able to see all 4 stages of cancer, 4 different cancer types. Diagnosis is given within 45 seconds. We also see diabetes types 2, very easy, by the way, even pre-diabetic conditions. So it's a groundbreaking, cheap solution to diagnose patients. Everybody knows here that the best outcomes of cancer treatments, that's dependent on the early diagnosis. And with this app, you can catch the patients very early. We are rolling out now in 40 hospitals in Central and Eastern Africa, working with some NGOs. The product got CE marking last year. We're also rolling out in Hungary and Romania, basically taking country by country. We're focusing primarily on the medical sector, GPs, clinics, health clinics, medium-sized hospitals that have a patient flow where most of the patients really come once a year to get their health check, and by integrating the app in a general health check, occasionally we do catch diabetes and cancerous conditions for patients that didn't even know they had cancer, stage 1 or 2. Very often these patients are caught very late, and we know this from the cancer world, oncology. So if we can integrate this Pluralistic into general healthcare, then we might be able to improve outcomes of oncological and cancer treatment.
Yeah, and here it goes again, back to the prevention. As Andrea was saying, the earlier, the better the diagnosis is, the better is the treatment options. And it is very, very uncommon that dentists or surgeons are checking out on a regular basis the intraoral cavity for cancer. Some cancers, the dentist is the very first one who can detect it. So here again, my mission is to spread out the information that a very thorough examination of the patient is crucial. And as we said, or as I said in the very beginning, that some materials have an impact on our patients, and the bacteriological status and the microbiome has an impact on the patient. I was writing a paper a couple of years ago that rheumatism, for instance, has exactly the same cytokine pathway like the periodontitis. And we do not know yet which was earlier there, the egg or the hen. So once again, focus should be a little bit more on the prevention and probably the implication of new biomaterials and materials in dentistry. So we switched a little bit from using titanium to zirconia to ceramics in implantology. We're using today plasma concentrates to enhance wound healing process when we do the surgeries. The future dental implants for sure won't be made out of any material. University of New York City has now launched a patent for a biomaterial scaffold that is injected with stem cells and with growth factors. So in the future, we just use these things just to let a new tooth regrow. Pluralism means to think out of the box, and I really adore those technologies that are soon available for various people, various human beings. So thank you for the information and for the impact of your magnificent development.
So still, as you said, with this stem cells and other things which are coming into the picture, there is a foundation back in India which we are working with them. So they collect the DNA information of the people and they create a categorization for that. So they are into something called like, they want to identify DNA-based diseases for the people who are there in a country like Africa and in India, so that we can create a complete inventory with that. And we already have an option of interoperability and AI at the back end. See, if you have something called as data for 1 year, you can do the trend analysis. Trend analysis, something like we can able to understand what kind of pattern that the disease is created for what kind of DNA categorization is there. Once you have the data of the same patient for another 3 to 4 years continuously, we will be able to do the complete predictive analysis. So that if the DNA categorization is being done, and say for example, if a patient tomorrow is coming to enter into the healthcare ecosystem, and we already have this information about the DNA is biometric and all the allergic system which he has, allergic, diseases which he has had previously. So we will be able to predict something for him like after the age of 30 and 40, what kind of diseases might affect you, and when you talk about the preventions, which can also be taken care on a priority basis for each and every people before itself it causes. So we can make the pluralistic aspects into a different level of sector to make the people to understand what kind of things that they need to focus on. So this is how we plan. Like, there are multiple foundations which has come into the picture nowadays. As this one of the foundation who is working on this DNA and all. The other foundation is working on the energy sectors where they calculate only the calories of nutrition foods that which you need to work on so that the malnutrition can be rectified and all those things. I think it's going to play a vital role in the future. We are waiting for that to see how exactly the AI is going to do all these things in the back end. Andrew, you can.
Yeah, it's just to follow up what Marcel said. I think the issue we have, is that me? I guess that's me. I apologize. Sorry about that. The issue we have in Scandinavia is that even if you have technology available and you in terms of diagnosis or patient screening, find an issue, in order to get a biopsy, etc., you can sit and wait for 2 or 3 months. So just to get a confirmation, you can go from stage 1 to stage 3 cancer before you even get to the biopsy. So getting the technology integrated in a holistic system where you push the environment to get treatment much quicker, I think that will help. I think it's a key in general in the medical world. Once you go into private, it's different. But in public health, that's a huge issue. Is the waiting lists, old systems, blood tests, mistakes. So even though everybody talks about AI becoming a threat in some points, but in terms of healthcare, I think that's a huge benefit.
So I would like to ask you something like
it's fast-tracked.
Yeah.
Yeah.
So you are already working into the system where exactly the retina has been scanned and the information about the people can be identified through that. So what kind of complex issue that you have faced it when you're trying to do all these things for multiple
people? Our issue is regulatory process. So in terms of FDA and CE marking, the technology moves so fast that the regulatory environment is behind it. So when we submit data, they have to consider going from traditional medicine, medical devices, units, all of a sudden EMEA authorities have to look at software in terms of healthcare. And that has rocked the boat. I mean, FDA, basically Google 3-4 years ago, they had a huge department pushing for Google Health. And these software developers, they came with brilliant products. They got like a whole line of them. They submitted it to FDA, and FDA just pushed back. They said, that's not our department. But you need to get it registered. So what do? So now eventually they're catching up, and they are approving more and more AI-driven products. But we have the same issue in Europe, I think most countries, that the regulatory environment is really the bottleneck. So if we can AI the regulatory environment, that would be wonderful.
No, when we try to analyze some kind of place where, like in Australia, so they have all this information which is connected only with the government. So when they are discussing about having a complete data of images, the images volume was like too big for us, at least just in one small place, like it's a small town. I don't remember the place of the name of the place. So when we try to accumulate only the images, because when you do the MRI scans, there are other images which will be populated through that, and the videos which you are taking it through the other operating procedures which you are doing it and all. So this image data and video data was consuming more than 20 to 30 TB in one small city for the crowd of, I'm talking about like 50 or 50 to 100 and 200 people. So which was very big for us. If you go for cloud to do it, right now, the cloud, I would say that even the AWS or Azure or other things which is currently there in the market, right, they won't understand. AI is not in the full-fledged manner in the backend data. Because this container, once you start spinning a container, it will be running it for hours continuously. Say, this is for kind of an example, when somebody is trying to open your website, the website is open only once. So we can spin a container whenever it is required. So we thought like we will not be able to do much on the backend data side. Instead, we will be able to convert those images and videos into NFTs, non-fungible tokens. In blockchain, we call it as. So we convert those things as an NFT and have the people identity into blockchain. So everything has been interconnected, and it can be solved with a peer-to-peer connection where you don't have to worry about a lot of data management. So that's how it has all been. We are trying to solve these issues here. So once you talk about all these informations, how it can be done in the futurist aspects, it's in the hands of like people who do Andrew, like he's scanning this retinas and all, because you can do the biometric for a normal person, but it's not the same with a disability person. I have seen a person who is having complete disability. He doesn't have anything in his hands. Like there will be no lines or any kind of imprints is there in his hands. And there are other people who are not able to speak in a right manner because their jaws will be in a different, like they're completely disabled. And only thing what you can do is like you can scan their DNA, or otherwise, as I said, with a retina. Only these are the two things which is available with them. And for the blind persons, it's very difficult for them to access the healthcare in most of the times. So they need a separate assistant itself. So we need to focus on what are the gaps that we still have. We are still trying to identify that. And we are working with multiple foundations to identify all those things. Once we have an answer for it, yes, I think we'll be able to crack it down. But it's a long way, heavyweight process that we have to wait and understand how exactly it's going to happen. I think you want to share something about you were discussing. Yeah, for you, yeah.
Well, as I heard AI in the medical field, we use it already, especially in diagnosis, even in dentistry. So since a couple of years now, we have those X-rays that are capable of doing an AI diagnosis. So as you said, AI is not only a threat, there is a lot of opportunities. And as well as the speed of transport of information is crucial, and the speed of managing our patients is crucial, especially in terms of cancer treatment. Yes, in 3 or 4 months, stage 1 can turn into stage 2. So we need to adapt here to the needs and to the increasing numbers of patients that do suffer, and just to be able to address these problems on time and with a specific information tool that can deliver on a very fast base the information to the doctors. So yes, I do agree with you, both of you, that this is very important in the future, and it's not that everything has only a dark side. Of course, there is pros and cons, as we know, but for the benefit of the patient, I see a lot of opportunities.
So you might have come across a lot of medical devices, right? So how do you see the evolution of the medical devices?
Well, on one hand, I see, as I made a little introduction regarding the materials, I see that there will be a shift going back a little bit from metal restorations in the oral cavity to non-metal restorations in the oral cavity. I started to place my first ceramic implants now 16 years ago. I purely place now ceramic implants because all the metal behavior of a metal implant and metal restoration is missing, which is good for the patient. So we have no galvanism, we have no corrosion, we have no allergies towards any metals that are in the compound of the material.
Okay.
So that's number one. Number two, I do see the need of connecting doctors from different fields more and more together. Mm-hmm. When I read this beautiful topic, pluralistic health system, I would love more that any doctor from any different field should get the proper information and exchange knowledge on conferences, for instance, like these, just to see that there is more than the subject that we are dealing every day. So the internal doctors should go to the ophthalmology congress, the ophthalmologists should go to the dentist conferences and so on. The orthopedics should exchange knowledge with cancer treatments. So we should a little bit get out of the box where we are only a little bit like blindfolded in our own subject. I turned actually in the last 10 years a little bit more from focusing more on dentistry to the global treatment of our patients. So we give infusions to our patients. We check their status. We check their vitamin D status, for instance, prior to any surgery, which is crucial for us to achieve proper results. So it's not only like one piece that is like put together. We should see in a holistic way our patients, and here I see a very big need to improve things.
It's huge. The thing is that we have now, we launched the product as a test in an Indian clinic, and the Indian clinic is divided into, there's a holistic doctors and there's a traditional medical doctors, and both operate under different licenses, but it's one clinic. And we have caught some stage 1 cancer patients. First of all, they didn't know they were sick. They thought they were perfectly healthy. They came in just once a year to get the health check and the blood test. And we scanned the eyes and we saw, and we got the biopsy to confirm it. Yes, you have stage 1. And usually, if you're in the beginning of stage 1, for most patients at age group young till 55, 60, you could actually reverse it by lifestyle changes. But if you sit with a pure oncologist, they're not dietitians, they're not lifestyle doctors, they're oncologists. So they have a tendency to send you to your traditional medical treatments, right? But where you really, in the Indian clinic, they push them to the holistic doctors and they will make the lifestyle changes, and you actually can reverse it within 3 to 6 months. Diet, exercise, vitamins, and it's really simple, but it's not simple if you don't know what you're talking about. So I totally agree, it's a huge issue. Right now we have silos. Each specialty is in a silo, and they direct them in the silo, the patients, instead of sending them places where things can be solved fairly quickly.
That's right. So I think whenever you're sharing the data with the other doctors, so how do they come up with a result? Like this data has been, say for example, as Marcel is there in Luxemburg, if he is giving the complete discussion which has been happened with the patient and you're doing some kind of medical treatment to him, when you send the patient to US or to a country like India, is there any question from the doctors they will ask you to do any corrections or what kind of treatment that you are given, or it's like they will not contact you for anything else? How does it happen?
Actually, it's a little bit depending on the doctor. It's not common that we get or exchange all the information, which I would normally prefer. Some patients are really good prepared, others won't, or don't. So here I see, a lot of things to improve as well.
Yeah.
Exchanging of knowledge, exchanging of data, exchanging of information on the patient from all varieties of medical fields should be crucial and should be highlighted a little bit more. And we should not forget that, I'm a teacher, I'm a professor at the university in Spain, but still I consider myself being a student, a lifetime student, now since almost 54 years. But we should always keep an eye on new developments and new things that we always can learn. It took me probably in the last 5 to 6 years a lot of time to go deeper and deeper and deeper in those chronic infected bone areas that what we call like FDOJ, fatty degenerating osteolytic jawbone, that has sometimes an impact to the whole body in terms of migraine, in terms of problems with the joints. Some patients have shoulder, elbow problems. Others have leaky gut syndromes. And once we treated it with our concept, we cleaned those regions out, or sometimes it's just like only necessary to take out the metals of the patient. We can improve the general health of our patients dramatically. So here, once again, we should be more general doctors and not only focusing on the subject that we've been trained and focused for.
I think this is the first time in my life I've heard odontologists mentioning leaking gut. That's groundbreaking. We need more of you.
So I think to conclude from my end, I would say that we should be able to create a kind of a community where all the networks of doctors from around the world when come into one single place where at least they will be able to understand what is a doctor from other countries able to do, or where exactly he is put on. So whenever you're trying to communicate with that the patient has been, the transfer of the patient would be way more easier. I think that can help a pluralistic ecosystem to come into a better pace on healthcare. That's it from my end.
Yeah, same. Uh-oh, we're in trouble now.
Yeah.
Hi, I'm Shafi here. Question to Ram. See, everybody, we carry a passport to travel to one country to another country.
Right.
Can the health data can be stored in the passport in the form of chip or in the form of code, so that any unforeseen situations arises, then the doctors can, directly go through the health data and they can treat him better? Is it possible for that?
It is possible, because right now we are coming up with a NFC technology. Like I have a ring in my hand, it's an NFC platinum ring. So the ring can be utilized as an NFC technology along with the cards, which is a very low cost budget for the people back in India. So once they tap it right, it becomes a health passport for them. So if you have the health passport in your hand, wherever our ecosystem is getting connected, now if it is possible to connect with the other countries as well. There is a QR code also, easily you can bring up with the technologies. If you scan it, immediately you can get to know the basic metadata information of a particular individual. So for example, even if you go to any country, right, you will be able to scan the QR code. Correct. So through our website, if you scan the QR code and click on yes, right, you will get the name of the person, emergency contact, his age, his date of birth, and what he is allergic to. Say for example, if a person is met with an accident and you don't know about this person when he is already a diabetic patient, if you're trying to treat him without knowing the information, that is a very disastrous thing that you're doing to him. So if you have the allergic information, what he is, and if it is a diabetic person, you get to know about this thing. It'll be very easy. So right now we have that in place.
And it should be done for all the countries, I suppose.
Yeah,
Thank
it
you.
has to be explored.
Yeah, Andre, this question is for you. So you mentioned about developing a technology in the Western country and moving it to Africa. So can you speak about if you faced any challenges in doing so, and if so, how did you go about overcoming those challenges?
Specifically in Africa?
Yeah, and specifically about your iris-based cancer screening.
Yeah, the product, it has a 95% hit rate, so it's pretty high. We're still nervous about the false positive. We had one. But no, Africa is, we actually chose Africa because we wanted to test the product in the most difficult market. And of course, it varies from country to country. We do have issues, like in Democratic Republic of Congo, they call us and say we have no internet for 5 days, right? Or no electricity for 3 days. So there's more like infrastructure, logistical issues. But besides that, yes, there's one huge issue. The product itself is easy, it can be integrated in the whole hospital system, which, by the way, the modern hospitals in Africa are way more modern than they are in Sweden. They leaped from like Stone Age to the most modern. The issue is that if this, and it will become widely available, you might have patients diagnosed very early, but they have no access to treatment. And that creates a whole different problem. So in the beginning, when we developed the product, we thought opportunistic, this should be available to everybody in the world, right? And everybody who is 45 plus age should be able to have it on the phone, just scan themselves. The problem is, there's, first of all, liability issues like in US. US is, you will be sued out of your apartment, right? So we decided to target the medical community in a controlled environment, and only the countries and the general practitioners that have access to oncological treatment. Because a woman with 4 children gets diagnosed with stage 3 breast cancer and has no access to treatment. It creates a whole different psychological, traumatic problem. So yes, there is an issue. It's a positive product, but it can also create a lot of damage if it's not controlled in a proper environment. And if there's no access to treatment, which is tragic. You can say the patient will die anyway, yeah, but going through that process, I mean, people will commit suicide, right? So we do have issues to consider, and we're moving very slow. We're taking it easy. We're not in a hurry. And as we get validated data and we can handle it, the traffic, stability, consistency, then we'll go to the next step and make partnerships regionally under a medical controlled environment. So yeah, there are issues. It's primarily infrastructure, access to healthcare, and sometimes internet just disappears for 3 days.
Yeah, as a follow-up to that, can you speak to any regulatory challenges that you faced as you were moving from one place?
That's why we avoided FDA. We're waiting. Once we're mature, we'll need a partner in the US that will deal with the headache. Like Google. Google basically closed the department. They had 46 people doing this, and they just gave up. They closed. Now they're reopening because FDA is catching up. So we just avoided US, and it's very expensive. So in Europe, actually, it went, I wouldn't say easy, but it wasn't a huge issue as long as we took step by step. So we didn't get a class 2A, like a full diagnostic. We got a class 1, and then that means we can screen as a risk for cancer, and that has to be confirmed by biopsy. And once we have enough data, which we'll have in 3 to 6 months from now, we will submit the documentation, and then we'll get upgrade classification. So as long as you ISO standards and you follow general procedures, it's not a huge issue in Europe. And it's relatively inexpensive compared to FDA. That's a monster to deal with. And like we're launching in Dubai at the end of this year, and 2 clinics, and they deal with the authorities, and we supply documentation we have from Europe, and it's considered, it's approved, so it's just work and time. It's not a huge issue. They're catching up because it's moving so fast, they have to catch up. They either have to revamp the whole regulatory environment or they have to catch up. So I think it's easier just to catch up. And that's all for all regions.
Hi, my name is Dr. Rami Khalil. I'm an internist. This is a question for Dr. Ram, Mr. Ram.
Ram, yeah.
So I'm very fascinated, interested in the application of blockchain technology in healthcare. And I think it brings up topics of data ownership. Who should own patient data? Should it be the patient? Should it be a hospital system, a hospital organization?
So,
my specific question is, how can you reconcile the frequent need to augment or change one's health record with the inherent property of blockchain that it is immutable? And who should have the right, should patients have that right to modify their record if their health data is indexed on chain?
So that's a very good question, actually, because that's what I was asking him, Marcel, about, like, what happens when a doctor is sharing a data to a different doctor. See, there is a kid who was having an emergency, and the kid's doctor was not available in the city. And what happened is, like, we have taken that kid to a different doctor, and the doctor was not having the complete record what the previous doctor was handling it. So when we asked this doctor, right, he was not available, and later on we got him somehow. But he is not ready to share the data because it belongs to a different hospital. So that was a very challenging issue. So what we did is, like, we already had the records electronic based with the child, and we were able to share it somehow with a different doctor. But if you say for example, if we give the complete control to the patient of the data, right, there will chances of manipulation will happen, definitely. So this, it will become a readable format for the patients. And read-write operations can be given only to the doctors who are authorized and within the same network. Say, for example, a hospital A is having 6 or 7 branches with them, but they are not having an interoperability option. So once they have the interoperability option, right, even the same doctor who is working in the hospital with the multi-speciality places where you go and treat the patients, right, if he is having a separate clinic, that time he will not have the access to the data of the patient who is coming to the hospital A. So if he is coming into the network and creating an interoperability, then his clinic is also supposed to be mentioned there. So that was not happening. So we have created a platform where there can be a readable format can be shared to the doctor, even if he is not connected to the hospitals, even if it is clinics, right? So right operation cannot be given to everyone, as because once a data has been created, it can be modified only with the special permissions. Say, for example, a wrong information has been given, and some data need to be changed. It cannot happen without the permission of the admin or the person who is there in the major concern. There are different roles. So these roles has been defined how exactly we are handling the technology on the blockchain cryptocurrency way. So these definitely needs the roles, and with those roles and permissions only we'll be able to do it. Right now it's not happening, but this is supposed to happen because we are having trouble in having interoperability and the data manipulation which is already happening. Say the patients are already having a data in papers completely. It's a PHR records. It has to be converted to a EHR records. So that migration will take around 1 or 2 years to complete. Once the data has been completely migrated to EHR records, and that will be brought to the interoperability option between the hospitals which are connected to it. And then the network of doctors is being created, because what exactly we are doing is like whenever we are onboarding a hospital or a clinic, right, we are providing them a identity for that. It's a blockchain identity will be created on top of it. How exactly we are doing real estate on NFTs using blockchain and all, right? So it's the same concept. So using the same concept, we are creating identity for the hospitals and also creating the identity for the doctors. So once you have a verified identity for the doctors, right, this identity will verify the doctor where exactly he's got certified, what is clinical or the definitions of the numbers, whatever he is having, and other government records, which countries he's belonged to, how many hospitals he is connected to. So this will be published only to the doctors, not to the hospitals. And if the hospitals are having doctors and paramedical staffs, even the paramedical staff are also having the blockchain identity for them. And the roles which will be given to the paramedical staff in case of emergency if the doctor is not available for changing or modifying the data. But that will happen only with the approval of the same doctor. So this is how it's been designed as of now. If there is improvisation is required, then we need to go for the trend analysis where exactly it is happening. After a year of time, we'll be able to create we already have like 8 months of data from 27 hospitals, I guess, yes. So with those data, we already have a patterns created for those, all the trends. So with those informations only, at the back end, we have a data analyst who is working along with this. So the data scientist team is like 12 people are there with that. So each PHR records is been identified and converted to the EHR records. So that time only we got to know this paramedical staffs can also be included to it. This modification has been done only 2 months back. So we need another 1 or 2 years of data to understand how exactly it can become under certain regulations has to be created for it. Certain roles has to be created. Even say for example in south part of India, right? When you go, sorry, north part of India when you go, and that too in west side and all, there will be a lot of people who are controlling the complete data informations. They can modify your physical health records for joining gym and all, and also some kind of manipulated information given, even if you're not admitted to the hospital, they are giving the discharge summaries. So this kind of things is not is happening without the knowledge of the hospital owners as well as the doctors. This paramedical staff is doing it because they have the access for the admin roles, whoever is sitting in the reception to provide the data whichever it is required. So we try to solve those issues through the NGOs, and then only we got to the plan of creating a blockchain entity for them, for the paramedical staff itself. Now we have the roles control, and we give them the access card. Without the access card, they will not be able to access even the places of the hospitals. So if they are trying to manipulate the data, easily we'll get to know it can be tracked by the doctors or even by the admins in the hospitals. So that's how the data has been shared and the control has been shifted.
Hi, good morning. I have a quick question for you, Doctor.
Yeah.
For the FDA and the CE marking, what you mentioned I totally agree with it. In the past, it was, I mean, easier pathway to go for EU. And what is your experience under the MDR, which is like very rigorous and it's like time consuming, and even to the state that the EU has extended the time for registration for the MDR, because until only a few months before the deadline, set by the EU, it was only 15% or so of the companies have the MDR. So that's in line with your comment about to avoid FDA, totally agree. And I would like to hear your experience. Maybe it's good to share also some experiences, some good tips. How you approach this in terms of the new regulation, specifically the MDR. Thank you.
Very quickly, gentlemen.
Yeah. So we've been working with multiple aspects of like in Denmark and also in other countries called there is in Argentina. Argentina was not now. It was like 2 weeks back only we got connected. But in Denmark, we've been working with the dental regulations, how exactly they are doing it. And there are certain aspects which we developed an application which is completely different from the standards what we follow from India. So it is easy, but it will complex, what do you call that, data or other things which need to be created on a different standards is completely different from what we follow from India. So we have created the standards on US based as of now, and also from India complete regulations we already have these informations. But wherever we are trying to populate this, right, we need to understand more about from their end what kind of things that they already follow it. Because if we are generalizing the formats and giving it what we are trying to follow in one single country, that's not going to happen in other countries. So each and everywhere we do a market analysis and also a complete case history will be done. It's like an R&D team. So we are having the help of NGOs who are working already for 12 countries. So they are collecting the data. It's under the process. So we have to do an R&D about their systems, about their records, how exactly they are sharing it with the hospitals. Like I said, how in Australia and small city, what kind of data that you are trying to take it. The first stage is like envisioning. So as we are talking about a lot of number of data, first phase we focus is the planning on the data side. Next is on planning the standards and regulations, how exactly it can be integrated with the current software from Medawatar side. Third would be like in deploying this application to them on a test trial basis and to see what kind of trends and patterns will be created there. Once this is done, then we are good to deploy in other countries. Because without this research and development, right, we'll not be able to just enter into the market and show that. Because that's, you're trying to just sell your product. It's not your product that you're trying to sell. You are trying to solve a problem which is universally there. Once you're trying to achieve this universal problem, and if it is solved, you will have everyone an individual identity, and that will become the health passport. Wherever they travel around the world will be followed with a certain standards, and the data can be shared with any of the doctors. So people will not have any trouble in traveling, also taking care of the health wherever they are. So we wanted to identify and solve this problem. That's why we are doing all these things, because we know that it's a time-taking process. That's why we are connected with already 3 NGOs who are doing the help for us, and we are also funding them for taking information from them to proceed further for the other analysis and all. So this is how it is doing. But it's possible, needs time. As you said, it's a time-taking process, definitely. But we'll be able to accomplish it.
Can I have 30 seconds?
Thank you. Thank you so much.
30 seconds, yes.
30 seconds, sir.
Okay.
My experience is as an angel investor I've been doing this for a long time, not my first rodeo. Very often, there's a focus on clinical data and the product. And that is supplied to the governmental agencies. And then they come back and say, what standards do you use? So very often, you like in Europe, ISO standards, right? ESO standards. If you start setting up your standards for documentation flow, so set up the base, ISO, whatever, it's very painful. But once you get that integrated, then you get a fast track. But if they're going to come back to you and say, what standards do you use? Then you have to start again from beginning. So it's a process.
Thank you. It was good to hear someone still positive about the MDR, but yeah, thank you.
Thank you.
Thank you very much, gentlemen. Ladies and gentlemen, please put your hands together for the panel. Sadly, we're all out of time.
That's it.